That way I can put it on the YouTube channel and welcome everyone. I have a couple of people coming in now, Jean, so I'm just going to give it a minute.
Sure. Oh, sure. No worries.
You're so important, Jean. Someone's in their car.
Well, I hope they're not looking, just listening.
So it seems like everyone's in, so we're going to get started. Good morning, everyone. We want to welcome Jean. I'm trying to.
Good morning.
Good morning. Let Jean get started since she has such a wonderful presentation prepared for us today. I'm sure everyone knows Jean from Acevedo Consulting, so we'll just let her take it away. Thank you, Jean.
Thank you. Thank you. Hi, everybody. I hope everybody's enjoying this little bit of nip in the air. I know I am. I've got on socks and sneakers and long sleeve shirt, but it feels good. All right, let me get rid of, I love seeing everybody, but you're going to block my slides. So let me get rid of all that. All right. So, first, before I forget, because it literally maybe an hour ago, hot off the presses, the Secretary of HHS, Becerra, has extended the public health emergency for another 90 days. So that means that, and I'm going to talk about this a little, more later anyway, but just so that you know, everything that we're used to now for the last couple of years, with telehealth, et cetera, is going to remain in place January, February, March, April, till sometime almost mid-April, right? And there's a little more detail on that I'll be giving, but Laura in my office spotted that just a little while ago. So this, guys, is, my goodness, let me take a drink. This is not the time for a tickle in my throat. And I know this is green. It's not a Michelob, it's Pellegrino. So this is the talk that we've got 2 hours noted for. So I'm going to ask if everybody could mute themselves, please, so that we don't have background noise. And of course, the Medical Society is recording us so that they can put it up on their YouTube channel. All right. Oh, this is just about me. So yada, yada. Let's move on. The disclaimer for this talk, I always like to stop at, because 99%, of everything that I'm going to talk about is brand new. So interpretation of all of it is, of course, not tried and tested yet. But as usual, I've done my best to provide you with thorough and accurate information. But you notice I didn't use the word complete, because for especially the codes, I'm not going to give you, you wouldn't want me to, hopefully, all of the documentation that's in the code books, right? So I'm hoping that each of you in your office has at least one current, i.e. 2023 CPT and ICD-10 code book. And then depending on the practice, you should probably also have a 2023 HCPCS book, right? So, let's get rolling here. What am I going to talk about? Well, as usual, changes to CPT. I will go section by section through the book. And I just realized that when I would do this live, I'd ask anybody in neurology here, and if no hands went up, I'd zoom past that section. So, oh well. So I'm going to talk about the other E&M services. You probably know, since it's already, what, the 10th, 11th of January, that all of the changes that went into play in 2021 for office visits is now the methodology for your physicians and non-physician practitioners to choose the level of service for their consultations, their hospital visits, their nursing home visits, their home care visits, et cetera. You'll see that there's a bullet there, CPT versus Medicare, because there are a couple of changes or new things in CPT that the Medicare program has taken a little different perspective on. So important to understand that. And then obviously with the Medicare physician fee schedule rule being final as of November, so just probably less than 2 months ago, need to talk about changes in that. And I literally have had to add, I think, like a little pop-up to 1 or 2 of the slides for things that have changed since I put this together not that long ago. So another reason for the disclaimer, because things are in a state of flux at the beginning of the year. Be ready to look for MedLearn Matters articles, et cetera, to further explain some of this. All right, CPT. And again, not all code changes are being discussed. I may not have full descriptions on my slides, et cetera. My intention is to make sure that you're aware of, in the sections that pertain to you in the organization or practice that you're working, that you, and hopefully you share the information with your clinicians, know what's changed. All right, so how many changes do we have this year? Well, 224 new CPT codes, but not really. I mean, technically, yes. But if you look in this table, the pathology and laboratory procedures, 82 new codes. Most of those are these proprietary lab codes, the PLAs, which are not going to impact any one of you, I'm going to probably pretty safely assume. So we've maybe got, what, 150 codes or something, right, that are new. So not that bad. And deleted 74. And of course, you need to pay attention to what's deleted in the areas that are being billed in your practice so that you don't get a denial for a deleted code and have to resubmit, et cetera. It's always good to do things right the first time. All right, so here we go, our section by section. E&M. Well, unless you're a radiologist or a pathologist, your specialty is probably documenting, coding, and billing and hoping to get paid for evaluation and management services. You cannot be doing that correctly anymore unless you have the current, i.e. 2023 CPT codebook, or at least has gone up to the AMA's website and downloaded the excerpt from the CPT codebook of the evaluation and management section of the book. And we all probably recognize that the AMA doesn't give away anything. You know, the CPT codes are very proprietary, and we can't get a free set of them. But because this change is so important to the medical community, the AMA, just as they did in 2021 for office visits, has indeed put up a free PDF version of the evaluation and management documentation. And the entire guidelines in the section, the beginning of that section of the code book, have been revised. And then we have a whole bunch of things that have changed and what I'm calling now some combo codes, et cetera. So from the pure coding perspective, where there have been up until now a set of hospital care, hospital visit codes, right? 99221, 2 and 3 for the initial hospital care, and 99231, 2 and 3 for subsequent hospital visits. And then of course, 99238 and 39 for discharge services. If the patient wasn't inpatient, so that what I euphemistically have called for probably 20, 30 years, that 23-hour admit, so observation care, had their own codes, right, for the initial observation care and subsequent, et cetera. Those codes, 99217 through 99220, don't exist anymore. And I'm going to talk about that in a moment, but if you think about it, that creates a bit of a problem because whether the patient is inpatient or observation care, so technically outpatient, you'll be using or should be using the same code sets. The levels of service do indeed remain the same though for this combo set of codes. Consultations, and I know a lot of practices don't bill any consultations. And I understand why, because in 2009, 2010, we all heard that, well, Medicare is not paying for consultations anymore, just bill the appropriate E&M visit code, right? And what a lot of physicians and their staff heard was no one is paying for consultations anymore. But that's not necessarily the case. I remember helping a local physician with an audit with Florida Blue. And they kept downcoding his level 4 services. And in his specialty, I actually can't even imagine how we could have lower than a level 4, except extremely rarely. And when we actually had a phone meeting with the powers that be and coding and auditing with Florida Blue, before we hung up, and this is a sub-specialist I was working with, the auditing manager for the state of Florida for Florida Blue actually said, "Doctor, we noticed that most of your new patient visits that you're billing us are actually consultations. So you've been losing money because they pay a good $40 more for a consultation." So I've always been an advocate for physicians capturing all the revenue they're entitled to. So don't necessarily think that no one's paying for consults. If Florida Blue is a decent payer for you and your doctor does indeed do consultations in the office or in the hospital, you might want to consider looking at how you're billing. Now, you'll note that the codes I've listed here appear to be missing the level 1 consult. They're not missing it. There is no 99241 or 99251 anymore. So other than that, the numbers of the codes still exist. Nursing facility codes, so they haven't changed really other than how you choose the level of service. All the codes still exist. CPT hasn't, the AMA hasn't taken out a level of service. If I was doing an actual E&M session, I would be talking a bit about how the AMA in CPT have added a component of complexity as help in choosing the proper nursing home visit level of service that is only for nursing homes and isn't in the medical decision-making table. So, and for anybody who's a nursing facility physician, right, does the admission, does the annual initial and the annual visit that's required by CMS, the annual assessment now, the code for that, 99318, has been deleted. So the physician who is doing the annual regulatory assessment would just bill the appropriate subsequent nursing facility E&M code, depending on the documentation. For anybody who's doing visits at home, and I know that that's a growing area of practice for physicians and non-physician practitioners, this is an example of another combo code. So up until January 1, there were a set of codes for going to the patient's private home, house, apartment, condo, and another set of codes if the patient was in a domiciliary environment, so assisted living facility. The CPT has combined them again, hence my combo codes, into one code set. The numbers of the codes are the old home care codes. So it's now home or resident services, no separate codes for patients seen in an assisted living facility. You'll notice that I did not, because I can't, have just a from and to for the levels of service, where the CPT has eliminated level 1 codes in most categories where they're eliminating anything, right? There's no longer, since 2 years ago, any level 1 office visits. There's one other thing that I'd already showed. The level 1 consults don't exist anymore. For some reason, for the home or residence services, there is still a level 1 for a new patient visit, 99341. And what they eliminated was 99343. When asked, the answer I got was that they were trying to be consistent. And I don't know about you, but it doesn't sound consistent, but oh well. So 99343 doesn't exist anymore, which is, of course, an interesting scenario. The established patient visits are still the same numbers, right? The same codes, 99347 to 99350. And of course, really, as in everything else, all the guidelines have changed. No longer for any evaluation and management service, and I said any, that's kind of all inclusive. Let me think. Yep, no, I think I'm right. Will any of your physicians, physician assistants, nurse practitioners be choosing, or should they be choosing, the level of E&M service based on any bullets? So there aren't any longer any requirements for how many review of systems are performed and documented, the extent of the physical exam, or whether or not they documented family history appropriately to avoid being downcoded. Those rules that physicians have lived with since the mid-1990s don't exist. And remember, this is a CPT code change, even though CMS, so the Medicare program, has gone along with 95% of all of this. It's not just a Medicare change. So this impacts every payer. Yep, this is not just a Medicare thing. This is the thing, right? I keep getting questions, even for office visits, which was the first round of these changes in 2021, about, well, Jean, but thank you, tongue. How comprehensive a physical exam do I have to perform and document to bill a level 4 new patient office visit? And my response is 100% of the time now the same thing. Only a clinically appropriate history and or exam, if either of those or both are performed, and nobody's counting bullets anymore. So this is the type of change that physicians, I very often have been able to say, I keep doing a mental happy dance for this, right? And once physicians learn it, they also realize that, oh my God, this is so much better than what we had before with the 1995, 1997 guidelines. But because we have some combo codes now, and we have a level of service like a 99343 that has been eliminated, there are some practical considerations that I want to make sure you guys consider. So if you think about just the hospital versus the observation care codes, right? Or the home visits versus assisted living. Well, you're only going to get from the doctor the code, right? How are you going to know whether or not that patient was admitted to the hospital? So you're going to bill on the claim, place of service 21, or was the patient just in observation care, never officially inpatient, which is place of service 22, when you're going to get the same codes regardless. So from a practical perspective, you really need to make sure that you've given some thought to how is that actually determined in your billing system? How are the codes communicated to you so that you'll be able to make that determination? And obviously we all know that if it's done wrong, especially with the hospital codes, wrong place of service when the patient was actually at another level of service in the hospital, inpatient or outpatient setting, you know what's going to happen. You're going to get a denial, right? So, so really important to figure out how to do that. And then for other sets of codes, if you do home care visits, consultations, where there's a code that's no longer in existence, right? Level 1 consults in the office or in the hospital, level 3, 99343, new patient, home care, assisted living facility visit. How do you, in your system, eliminate that code, right? So that someone doesn't choose it any longer, and yet make sure that it's still there so that if you need to respond to a payer audit. One of your clinicians comes at the end of this month and says, oh, I forgot to give you all these new patient visit codes, right? How do you make sure that it's still in existence, but not there to be chosen again, right? So just some things that I know I've had these questions in my mind since I saw what they were doing in eliminating or combining codes as to, oh, what are they going to do about this to make sure, they being you guys, right? And if you think about this, now what I've said about the E&M codes, so there's a whole new way to choose the level of service. Medical decision-making or total time on the day that you saw the day that the clinician saw the patient. One or the other. No more bullets for review systems, no more bullets for physical exam, et cetera. No more counting elements of the history of present illness. Clearly, all your providers need to be educated. And if you have anybody in the office who is even, whether or not they're coding the services, but even validating sometimes, right? Clearly, they need to be educated on all of this, right? So this is an area for that really cries out for education. All right, that's it for E&M. Anesthesia, we're going to move on. Next section of the CPT codebook, moving on, because there were no changes, no new codes, no revised or deleted codes, etc. Hey, so I just realized that there I can see chat. So let me go in. I guess at certain points I'll go into the chat so that we don't find ourselves having ended and no questions have been answered. All right, so let's see. Well, there's
we don't have any questions in the chat right now, Jean.
Oh, I thought I just saw one about nursing home or something. Yeah, our nursing home residents not skilled billed as nursing home 99304 or home. Good question. The only payer that I am aware of that considers a nursing home setting, skilled or non, as the patient's home is Florida Medicaid, right? So a patient seen in the SNF or the unskilled portion of a nursing home would be billed using the actual nursing home code. So 99304, 5 or 6 for the initial assessment, et cetera. Okay. All right, I think that one, Mindy, went directly to me. So, all righty. So,
thank you.
Yeah, sure. Surgical section. So I'm going to go little subsection by subsection, right? And see where I want to point you depending on your specialty. All right, so first section, integumentary. Well, there are a few new codes, and what I find interesting are some of the parenthetical guidelines. So one of the new codes, 15778, is an implantation of absorbable mesh or other prosthesis for delayed closure of defects due to soft tissue infection or trauma. So if this is a surgery that your physicians do, really need to pay attention to the parenthetical guidelines because they really are instructive for this particular code. The area in this section of CPT that I found interesting were the 2 new codes for suture removal. And that's, for some of you, I'm sure you realize this has always been an area of question. Can we bill for removing sutures? Right, so, and my general answer would be, well, it depends. So we have 2 new codes now, and they are add-on codes, meaning, of course, that they are never billed alone. They get billed with as an add-on to whatever the primary procedure was. So the first one, 15853, removal of sutures or staples not requiring anesthesia, and 15854, removal of sutures and staples not requiring anesthesia. So obviously the level, the 353 and 54, 53 is going to pay a little less, right? Because it's either sutures or staples. What I find interesting is that there are a list of codes, E&M, some of them, right, that are listed in the instructions as the primary codes. That would be the base code, right, that you have to report, that you can report, and then that you report and then can bill this one of these add-on codes. One of them is 99211, that infamous nurse visit. And I know if I had a little less knowledge and I saw that, I would be thinking, oh, okay, So if the patient comes to us for suture removal, and we can indeed bill for suture removal, right? I mean, it's outside of a global period. We didn't, we weren't the practice that actually did the repair, et cetera. Then I bill 99211, a nurse visit, plus whichever one of these suture removal codes is applicable, right? Well, this is where CPT and actual billing and getting paid don't necessarily see eye to eye. So for anybody who's in a specialty area where your office nurse may indeed be removing any type of sutures or staples, please understand that if you're billing these two codes, just as anything else where there would be two codes on the claim, each code requires its own unique documentation. So if indeed the nurse, the office nurse, has removed sutures and or staples, what is the evaluation and management code underneath? Where is the documentation? What evaluation was she asked to do by the physician, et cetera, maybe teaching, et cetera, right? So I find it interesting that 99211 is listed as a primary code, i.e. the base code, right? For these add-on codes. Be interesting to see what happens if anybody is billing those. Okay, musculoskeletal system, one new code. There are indeed a whole bunch of guideline renewals, revisions, primarily for insertion of drug delivery devices. If your practice is billing anything from 20700 through 20705, you really need to read the guidelines and the parenthetical notes, et cetera. For the orthopedist, the one new code is, again, an add-on code, 22860. Total disc arthroplasty, anterior approach, second interspace lumbar. Okay, so clearly that gives the surgeon the ability to more appropriately and easily bill for additional interspaces in the arthroplasty. And that's used, of course, with CPT 22857. Was it for musculoskeletal? Respiratory, again, one new code, right? 30469, repair of nasal valve collapse with low energy, temperature controlled, submucosal or subcutaneous modeling. This is primarily going to be for the otolaryngologist. Again, it is a must read for all the parenthetical notes, et cetera. Up until the creation of this new code, this type of repair for a nasal collapse was supposed to have been properly billed with the unlisted code 30999. Right? So this is a good thing for the folks who are actually doing this. So maybe, you know, ENT, plastic surgeons, et cetera. So that's a good thing. But that was the only code that really for that subcategory. Cardiovascular, 7 new codes. Well, any of you who have heard me do this talk with any frequency know that I'm typically wanting to say that who the heck is it at the AMA who has it out for cardiologists or cardiovascular surgeons that they're always changing up the codes for them. This is typically the one physician professional service area of CPT that has the most changes. And I will tell you that if you're performing any of the codes in this 30,000, any of the services represented by these 30,000 CPT range of CPT codes, you really need to. And let me make it clear, when I say you, I don't just mean the management, coding, billing, the doctors, right? If you stop and think about it, if the physician is not aware of new revisions, new codes, revisions to descriptions, et cetera, and when to bill and when not to bill certain codes, if they're not aware and you get a request for records, their documentation of the procedure may or may not support the new billing requirements, right? So giving that to the physicians is really a very wise thing. I know with the changes to office visit codes in 2021, I often, in sitting with a doctor or a nurse practitioner, physician assistant, would literally stop my education, assuming I'm one-on-one, not this Zoom stuff, and hand them the outtake that had all the new guidelines for E&M documentation and coding, and sit there and make them read a couple of paragraphs, right? They may have initially when I started asking, but I was real careful to make sure that I didn't do that with something that was not going to be worthwhile for the physician, right? And they all were glad and had a better understanding after, right? So, because when you think about it, excuse me, it is in the physician's best interest for the financial sustainability of the practice to make sure they understand the changes, right? So the main areas of revisions in the guidelines for cardiovascular shunting and cardiovascular injection procedures, coarctation of the aorta and its repair, and then in the percutaneous pulmonary artery revascularization by stent, as you can see, there are 1, 2, 3, 4, 5 new codes. And then percutaneous arteriovenous fistula creation, upper extremities, 2 new codes, 36836 and 36837. And again, must read guidelines, right? You can't code this correctly or have it documented correctly. You may be coding it correctly, but whether or not the documentation actually supports it, I bet some, let's see, I bet a large pizza with extra cheese and pepperoni on half, one of my favorites, that without reading the guidelines, the physician's documentation is often not going to meet the code's requirements when the payer asks for it, right? So in the digestive system, there are 17 new codes, right? Most of them are in the hernia repair section. So any of the general surgeons who are doing hernia repairs, you really need to be given that section of the book or sit down and flip through it to see what procedures now exist that have their own codes that probably didn't before 2023. And what does it sound like with documentation that you need to make sure you've captured, right? So, so they're typically these changes or these new codes in the 5949591 through 49618 section for repair of anterior abdominal hernias, initial, including mesh or other prosthesis when performed, and reducible, incarcerated hernias, et cetera, are all the reasons, and the size and the length of the defect are all of the discrete differences between these 17 different codes. So this is a great example of why I repeatedly am stating that the physician needs to know what these descriptions and requirements and guidelines are to be documenting correctly. If the length of the defect is going to determine which code I get, how well and clearly is your surgeon documenting the length of the defect? Clearly it's going to have, should the payer request records, an impact on being able to keep the money, right? So it really is important. For the urinary and male and female system codes, there's 1 new code, but again, big changes in guidelines. So kidney incision guidelines have been totally rewritten. And how do I know that? I don't know about you, but think about what your code book looks like. Yours probably looks same as mine. When I get to a section and I look at the guidelines, when I see the font is all in a pale green, I know that, this is all new. I better read this, right? So the 1 new code is 55867, laparoscopy, surgical prostatectomy, simple subtotal neototomy, urethral calibration and or dilatation, and internal urethrotomy includes robotic assistance when performed. Now that comma, when performed, should be telling your surgeon that I get to bill this lap procedure as long as I've done everything in there, whether or not I've used robotics to do the procedure because it's robotic, includes robotic assistance when performed. So I don't have to have used robotics to do this procedure to bill the 55867, but it also means that if I'm one of the physicians using robotics for my surgical procedures, I don't get to bill any longer an additional code for the robotics, right? So it works both ways. No new or revised codes in maternity and delivery for the OB-GYNs that might be listening, but the guidelines have significant revisions. So big encouragement to make sure you read that. The nervous system has no new codes. However, if you're doing any type of nerve blocks and similar procedures, you cannot avoid this section. This is, again, a great example as to why it's so important to look at the guidelines. Every year, that's one of the things I do when I first get the CPT code book, is to go to the sections of the book for codes that I know that we work with physicians that use fairly commonly. So I need to be familiar with how and what the circumstances are to document and bill them. And I look at the guidelines. If one didn't do that for this, you're definitely not going to be billing correctly for some of the procedures, right? There's a new methodology for determining the number of levels for these paravertebral spinal nerve and branch blocks. And there's a whole new table in there. There are more codes that have imaging guidance included. So there's in the table, which is actually wonderful, they actually call out for you the procedure codes that do not include imaging guidance. So you know that you can indeed separately report the imaging guidance when performed, of course, right? There's a new table that includes the number of levels injected with cervical, thoracic, and lumbar sacral injection procedures with and without modifier 50, how many units it is, et cetera. So if anybody is performing and billing blocks within the range of 64490 through 64495, you need to read these guidelines. Right? In the eye and auditory systems, there are 3 new codes. Shocker, parenthetical notes need to be reviewed. And what I found interesting in some of the sections of CPT as more of the billing guidelines or clarifications, as I'm sure the AMA gets, I don't know, flack or gets claims data, right? That they realize that, oh, the way we said this may not have been clear. To give the example, below 69210, which is removal impacted cerumen, right? There's a parenthetical note now that makes it very clear that if the cerumen is not impacted, there is no separate removal code. It needs to just be included in the physician's evaluation and management service. And having done a fair amount of ENT documentation and coding audits and education, I know that one of the areas that I've tried to reinforce for docs is that when you're billing 69210 because you have removed impacted cerumen, you need to make sure that in your physical exam, you've actually documented that you have found impacted cerumen. Sometimes, I know in some EMRs, even if the physician did find that initially, because the result after removing the darn stuff was that the tympanic membranes is clear and visible, yada, yada, right? But you will have lost, one, the clinical indication for the cerumen removal, and now CPT makes it really clear that you better document that the cerumen was impacted if you intend to bill that code, right? So becomes more important than it ever was, because as we probably all know, if the rule is a CPT code rule, it doesn't matter whether or not the payer has ever zeroed in on it before. CPT is for every payer. The payer doesn't need to have its own policy They have the right to cause you problems when they've asked for documentation if all of the requirements and parts of the definition of a CPT code aren't documented. So I thought that was important. The code itself, again, didn't change, but parenthetical notes. And then, excuse me, there's a new, the one new code. A new code is 69729, new osseo-integrated implant code with transcutaneous attachment to external speech processor. And then there's more, but again, I told you I'm not going to give the complete definition necessarily to all codes. So for that code, it's equal to or greater than 100 square centimeter surface area of bone deep to the outer cranial cortex. So what do we have here? Okay, this is one of those that, again, we need to make sure that the, in this case, the surface area is well documented, right? So here's the implant. Then there are two other codes, 69730 and 28 for replacement and for removal. And again, since they are the extent of the defect in square centimeters is part of the code description, you need to make sure, or your physicians need to make sure that they are documenting that, right? All right, so from a surgical section perspective, that's it. Radiology, one new code. So they did redefine the extremity ultrasound code 76882. So if indeed in your practice that is a procedure that an imaging procedure that you perform, you need to go back and look at the actual definition of the 76882 to make sure that your documentation supports it. Now, from my perspective in reading this, I interpreted this as a good thing, right, actually. But now there's also this one new code, 76883, ultrasound nerves and accompanying structures throughout their entire anatomic course in one extremity, comprehensive, including real-time imaging with image documentation per extremity. So tells you clearly that this is a per extremity. So it doesn't encompass any bilateral ultrasounds that meet this definition, and is probably going to be helpful. Now, one of the other things where there may be no other new codes in the radiology section is guidance in the ultrasound section and the fluoroscopy section of the radiology book, where they have the list parenthetically, right, of do not code with or do not report with, right? And then it will list the codes that already include imaging guidance. So anybody who's doing ultrasound fluoroscopic guidance for procedures, someone needs to quickly go look at that and make sure that you are aware what codes not to separately bill for the guidance, right? Pathology and lab. Now I have discounted the PLA codes because unless I've got someone from Quest or LabCorp, someone similar on the webinar, we don't need to know about those. But there are 12 new codes in this section. Most of them are in category 3 codes and genomic testing. So I don't know that, that I need to really spend time on these audit codes. I'm sure there are some physicians and some highly technical subspecialties who are ordering these tests, but just to give you an example, 81441, inherited bone marrow failure syndromes, or 51 targeted genomic sequence panel analysis, an RNA analysis. So, I didn't find any changes that were worth mentioning in, like hematology and chemistry, et cetera. So, but depending on the specialty in which your office concentrates or practices in, you may want to look at some of these codes to see whether or not there isn't something that, oh, wow, there's a code for that now, right? Last section of the CPT code book, medicine. There are about 38 new codes. Shocker, most of them are for vaccine administration and the actual vaccines, and they are all about coronavirus vaccines. And this will probably grow. So for any of you who are administering any COVID vaccines, you should indeed be keeping track of when there's a new vaccine, making sure that you have gotten from the AMA's website the new code or codes for those, right? So because every time there's a new virus, there are new codes that come out, and it makes sense to me, right? If you think about how in the world does the CDC or the WHO know how many people have gotten the initial vaccine, et cetera, right? Is based on the claims data and which what do I want to call it? Which iteration of the coronavirus vaccine did they get, right? It's all from claims data and the codes that are used. So really important. So a lot in that area if your practice actually administers the vaccines. And then in the just general vaccine and toxoid section, again, significant guideline changes. So if you're family practice, peds, preventive medicine, et cetera, anybody else who is giving vaccines, you do want to go look at this one. Most everything in the changes have to do with coronavirus, but there is a new vaccine for dengue that is a new code 90584. So for immunizations, it's pretty much it. Now, there are guideline changes more than there are coding changes for hemodialysis, the miscellaneous dialysis procedures subsection, coronary therapeutic services and procedures, cardiac cath. Yeah, I mean, cardiac cath codes changed so much last year in 2022, but I guess we're not finished with that. Peripheral arterial disease rehab, pulmonary diagnostics and rehab. And this is one of those areas where the AMA, per CPT, has started to get more into actual billing than just codes. I've always looked at the CPT code book as it's a dictionary, but rather than words and their definition, it's been 5-digit codes and their definition. But through the last probably 5 years, maybe, I've noticed more of the actual billing reimbursement rules put into the CPT code book. Some of it should be very helpful. But for this particular one, and I find it interesting. I'd love to know what makes them put this type of guidance that I'm going to mention in a moment for some codes and not others. But anyway, for pulmonary diagnostics or pulmonary rehab, there is indeed now a parenthetical note that if a separate E&M code, evaluation management service is performed, you may report it. And then of course it talks about with modifier 25. Okay. However, in the allergy subsection of the medicine section of the CPT code book, it says, do not report evaluation and management services for test interpretation and report. If a significant separately identifiable evaluation and management service is performed, not full description here, it should be reported using modifier 25. So when I see that one very specific to saying, hey, don't bill an E&M if all you've done is test interpretation, something tells me that the AMA has gotten wind of practices who are indeed doing allergy testing, billing an E&M for the physician's interpretation of the allergy tests, and billing that as a separate service in addition to the test itself. So, just, I guess, a word to the wise from the AMA CPT. Orthoptic training under a physician, qualified healthcare professional, which is, of course, your nurse practitioner's PA supervision. We've got new code 92066. Behavior management. is something that not only has CPT added a whole new subsection. So in the medicine section of the book, up until January, there was no subsection for behavior management services. And this is one of those things that seems to be working pretty hand in hand with the CMS, which has expanded the ability for physicians and non-physician practitioners to perform and bill for behavior management services. CMS seems to be encouraging it, which is a good thing, obviously, right? So, but there is a new subsection and of course, new codes, right? It has to be if there's a whole new subsection, right? So 96202, 96203, they're time-based behavior management training without the patient present. So if you're a psychologist, a licensed clinical social worker, some other mental health professional who is doing behavior management services, please go to this new subsection in the book. Try to educate yourself to see if this isn't a service that you now have the capability or the ability to bill for, right? So I expect that we're going to see more on this. Therapy and rehab. So your physical therapy, occupational therapy, et cetera. Codes haven't changed, but there is a reminder there that therapeutic procedures require direct one-on-one patient contact. So all of the codes that have in their description each 15 minutes in this section of the book are direct one-on-one codes. And what that basically means is that I'm the physical therapist and I'm billing, say, therapeutic activities for you, right? Which is then each 15-minute code. During that 15 minutes, or however, even if it's greater time period that I'm performing therapeutic activities with or for you, I cannot be performing that or any other direct one-on-one patient contact code for another patient, because it's direct one-on-one. Well, it would no longer be one-on-one if I'm performing it or something similar to another patient. Now, for anybody who has physical occupational therapy in their organization, I very often hear from the therapist, yeah, well, no, we follow that. But obviously, if it's not Medicare, then we might have more than one patient. No. This is a CPT code definition. And again, when it's in CPT, it's all payers. This is if the floor is too busy for one physical therapist, say, to be able to do these one-on-ones, that's the time when maybe to think about adding a physical therapy assistant. For acupuncture, osteopathic manipulation treatment, OMT, and chiropractic manipulative treatment, the guidelines have been revised again. So any DOs doing OMT, anybody with acupuncture, any chiropractors, again, need to look at the guidelines. Nicely, the AMA has made it clear that a separate evaluation management service may be reported with modifier 25. Now, what the AMA has not done in the code subsets that they've said that a separate E&M can be billed with modifier 25 is to make it really clear that, well, before you do that, make sure that the evaluation management service is indeed separate and significantly identifiable from whatever other service you're billing today, right? So don't get too comfortable with that verbiage. I'm not quite sure it's there for these services, which can be helpful, but it also can be a little misleading, telling you that, oh yeah, I can bill a visit too, right? Without understanding the real criteria for modifier 25. All right. Other medicine sections, right? So it isn't enough to have its own real subsection. So remote therapeutic monitoring and remote therapeutic monitoring treatment management services have had significant revisions to the guidelines. this line or this area of medicine is growing by leaps and bounds. Since there was the remote physiologic monitoring, right? RPM. So we've got RPM and we've got RTM. This keeps changing, growing as medicine has more AI, more technical ways to monitor and assess and aid in the treatment of patients, et cetera. So interesting to watch this grow, and know that if you are doing any remote therapeutic monitoring or treatment management, again, you need to go back and check the guidelines. One new code in this area, 98978. So this is when you're providing the device, and it must have scheduled, for example, daily recordings and or programming alerts. And as with most of the codes, it's for a 30-day period. So Category 3 codes. So this is a section of the code book. Sometimes I used to call these, new technology codes because they all end in a T. This is an area of the CPT code book that never gets the attention that it probably should. And there are more than 60 new codes that I spotted in this section. I'm not going to talk about a bunch of them, obviously. But here's why I like to bring it up. If you think about, and I'm not an expert by any means in the CPT editorial panel's process for adding new codes, but I know enough to be dangerous. So I'm a provider, I'm a device manufacturer or something. I go to the AMA, and obviously this is very high level and very loosey-goosey, because I think there is no CPT code currently that describes this item, this service, this approach to the service for a code. The AMA has its procedures, obviously. And if it is something that is kind of like new technology, which is why I always call it that, they may say that, okay, let's assign a new technology code. This looks like it might have some benefit, and you've proven to us that it's in use somewhere, right? So we'll create this new technology code for it. How does that new technology code get to be what I always call a regular CPT code? When does it move to the front of the bus? Only if after, I can't remember if it's 3 or 5 years of use, which means billing reported on claims, the AMA can see that it is indeed reported with enough frequency to raise its status to a level 1 CPT, category 1 CPT code. So this section of the book, I try to remember to advise folks, when you get your New Year's CPT code book, go to the category 3 section near the back of the book and just look to see whether or not there is anything that has been added that is something your docs do. Now, there are no categories or subcategories in the category 3 codes, right? So you're not going to be able to go look and find all the cardiovascular ones, et cetera. They add, and of course, because they don't know what's coming, right? So they add the new codes on to the current list. And obviously all the new codes have a red dot at the beginning, right? So they're easy to spot. And if you find something or your docs find something, go, oh, wow, I've been doing that, right? Then they need to get a comfort level as to, all right, what do I need to document? What do I need to know to build this? Because even if initially there's not necessarily payment for it, it's the consistency and the frequency of reporting it that might move it to the front of the book, right? And category, the actual CPT codes that aren't just category 3, new technology, right, are accepted by most payers, right? Much more so than category 3. So it behooves you. So here's an example or two of, I just picked them out at random. Digital pathology, digitization procedures. So, and this is an add-on code, 0751T. Digitization of glass microscope slides for level 2 surgical pathology, gross and microscopic exam. Okay. So this is an add-on code for the surgical pathology code 88302. So if I'm the surgical pathologist and I didn't know that this code existed, I might not be being paid for this, right? So even for a pathologist, worthwhile to look to this section of the book. And then 0725T, vestibular device implantation, unilateral, or 0743T, bone strength and fracture risk assessment, right? So all different types of specialties you'll find back there. And again, they're listed at the end of the CPT code book in the category 3 appendix. Modifiers. No major changes. There are a couple though. I think it was last year that modifier 93, so telemedicine, telephone only, basically, right? You have the full longer description there, became a thing. There was a code, there was a modifier and a description. But I do not remember ever seeing anything last year that said that you needed to append it to telehealth, especially for the Medicare program. It was always add modifier 95, right? If you're providing a telehealth service. Well, effective 1/1/23, any approved telehealth service that is provided via telephone only, so no audio, video, no FaceTime, no WhatsApp, DoxyMe, whatever it is you're using, is supposed to have modifier 93 on it. So a couple of things stand out to me with that. Well, there already are telephone codes, right? So if I'm evaluating and managing the patient and it's only on the telephone, no video component, 99441, 42, and 43 would now need, at least for the Medicare program, to be billed with modifier 93 because they are, by their definition, telephone only. But then if you were to look at the list of approved or covered codes for telehealth, you'd find other ones that, looking through this big spreadsheet, say, yes, you can provide this via audio only. The first service that I think of for that is advanced care planning. So advanced care planning, discussion about, advanced directives, et cetera, is 99497, time-based code, right? Each first, 30 minutes. Can be provided in person, can be provided via audio video, now during the public health emergency, and has a little Y for yes, it can be provided audio only. So that would require modifier 93. So I would suggest that for any service that you're providing via telehealth, that you go to the CMS's current list of covered telehealth services and look for that.
The prices are on that board and they're making
So
it now.
someone needs to.
Hello. You check them in.
Hey, someone needs to mute themselves. Thank you. So there's a column, audio only, I think is the heading, and there's a Y, and for those services that can indeed be performed and reported, i.e. billed and paid for, audio only, and see what you might have, you might be performing and providing to patients that you need to now add the modifier 93 in addition to, say, the telephone codes, right? Depending on your specialty, the 2 new HIPAA modifiers are going to impact you. So one of the changes in the physician fee schedule rule this year is to allow audiologists to personally provide some audiology testing without an order from the physician, right? Expansion of the audiologist scope of practice from a billing and payment perspective, right? So, and you have there the full definition for modifier AB. Medicare obviously has limited the circumstances under which the audiologist can just on his or her own provide services without an order. The modifier definition pretty much tells you what that is, but if you're implementing that, if you're otolaryngology practice or anybody else who has audiologists for some reason, make sure you understand this and make sure that you now have internally a process to document to have it be clear whether or not the physician ordered the non-acute hearing assessment, or if the audiologist did it on his or her own, right? So that you use the AB modifier appropriately. There's no payment differentiation, right? So, don't have to worry about that, just the new process to make sure that you implement. And then for anybody who is doing drug administration, especially infusion services, so rheumatology, oncology, allergy in some circumstances, some GI, or even neuro now with the Ocrevus. So you probably are well aware of the fact that if you're using or your nurse is using a single dose vial and there's any drug wastage, that the drug wastage needs to be documented in the nurse's flow sheet and needs to be reported on the claim. No negative impact on reimbursement. It's just that, and I know exactly why CMS started that JW modifier back in, where are we, about 5-6 years ago as a requirement for payment, is that there were folks who would actually use in a single dose vial the overflow or anything that wasn't used. So it's a 10 milligram vial. I only used 8. So take that 2 milligrams and pool it with something else so that I had another 8 milligrams to administer to another patient. Used to make my skin crawl when I'd see that that was happening. So, very important. But for whatever reason, so CMS really must not be too comfortable with the way this is being done. And I know when we do chart reviews, we very often still find that drug wastage might be documented in the nurse's documentation, but not on the claim, right? So now they have a new modifier right now, JZ, 0 drug amount discarded or not administered to any patient. So if it's a single dose vial and the entire vial has been administered to the patient, as documented in the nursing notes, and obviously it's actually performed, JZ modifier needs to be on that HIPAA code level on the claim. So those are 2 new, two new and 1 existing last year, but finally implemented modifier usage. So need to be aware of those. HIPAA, didn't have my HIPAA books for the longest time. So, and obviously there are always drug and biologic changes, et cetera, but there is one area that for some of you might be important. So prolonged services, the extra time, right? Since especially now that evaluation and management services in all settings can be chosen based on what's the complexity of my medical decision-making, or how much time did I spend today, pre-visit, intra-visit, post-visit, as long as they're all on the date I actually had the visit. And so what happens with extra time? How do I build that? CPT has its own codes, 99417, 99418. The AMA continues, and I understand some of it, to not like the wording for prolonged services in CPT. So to make sure that for Medicare patients and Medicare patients and who have Medicare or other payers who follow Medicare's coding criteria. Medicare for 2021 created the G2212 prolonged services for patients seen in your office outpatient setting, and now have 3 more for prolonged services in the hospital, whether inpatient or observation, for the nursing home, and for home or residence, right? So they will not accept the CPT codes for prolonged services. And the Medicare program has made it really, really unequivocally clear that to be able to add a prolonged services code to the E&M CPT code, you must have provided at least the 15 minutes for each code. Right? Now, these are each 15 minutes, and there's right now, there's no edit as far as the amount, the number of 15 minutes. Make sure your documentation is clear and it appears medically necessary, et cetera. Obviously, if you're using a fair number of units or prolonged services, of course, but So, but if you spent 10 minutes in addition to the E&M code, you can't bill a prolonged services code to the Medicare program. It's got to be at least 15 minutes. For physicians, non-physician practitioners who are actually billing based on time, whether the base E&M code and or prolonged services, please don't do things like, so like a 99214 in, oh goodness, I'm not going to remember these things off the top of my head. So let me forget that example. So 99222, mid-level hospital admission or observation admission now, right? If you've spent 50 minutes, it's not a 99223 because that's at least 60 minutes, et cetera, right? So make sure that everything is really clear and you don't do an about, sounds like, or use just the same amount of time for each service. All right, that's it for coding. Let me just make a quick look. All right, so there's one question that I see. Just to clarify, with the hospital coding for inpatient and outpatient, I understand the codes are combined together. Did you, me, say, excuse me, regardless of the code, the place of service needs to be correct? Yes, I did. As inpatient, place of service 21, and outpatient, place of service 22. Yes, that's exactly what I said. The same thing is going to be at issue potentially for physicians, nurse practitioners doing home visits, because there's also place of service 12 for home, place of service 13 for domiciliary assisted living, et cetera, right? So yeah, how to have that, excuse me, the actual place be communicated so that they can build with the right place of service that's going to be one of those practical hurdles, right? So yes, thank you for asking the clarification. All right, so how much time do I have left? All right, I should be able to go through the physician fee schedule on our last half hour, 40 minutes or so. So you see, I put a big red X behind over this first paragraph, because when the final rule first came out, everybody, myself included, was like, holy expletive, right? They've inputted a 4.5% reduction in the conversion factor. We've got 4% reduction because of sequestration, because what Congress did a couple of years ago was never renewed. Holy expletive, right? Thank God that with the omnibus bill that was just approved by both chambers of Congress and signed by the president, most of that is gone. So what the bill did was to eliminate the 4% pay-as-you-go sequestration for this year, 2023 and 2024. So that minus 4% that was going to hit everybody for every service will not, notice I didn't say is not, will not be in effect for 2023 and 2024. What you all have to be aware and alert of, especially the physicians with the FMA, the AMA, and their specialty societies, and managers with the MGMA and other manager organizations, is that they're coming back in 2025. And it might be one of those accumulative things like we used to see, 10 years ago, or whatever it is now, with the sustainable growth ratio, which it just kept accumulating and accumulating, so that one year it was like physicians were set to have 33% of their reimbursement reduced, right? Something really draconian. So lobbying, paying attention is going to be important. The conversion factor is still reduced from last year, but it went from 4.5% reduction to a 2.5% reduction for 2023. Now, the current, if I'm understanding all of this correctly, and I think I am, if you go to First Coast website to get the 2023 fee schedule, try to figure out what you're going to get paid for each of your CPT codes, you're looking at the fees, the reimbursable allowable amounts from before the omnibus bill was signed into law. I have yet to see an official notice from CMS that, hey, we've gotten all these changes. We will be issuing an update and revision to the code, to the fees. And many of you can remember through the years that this happens every once in a while, right? Sometimes they will, like First Coast, will take down the fee schedules. They won't exist anymore. And we'll be told that from this date to that date in January, typically, they're not going to pay claims because they're updating the files, right? It's a lot easier to stop and do that and pay you correctly than it would be to pay you on an old fee schedule and then have to update payment for each and every one. Plus, in the long run, it's actually easier for you because those additional 20 cents or $2.59, while welcome to receive it, is not easy to have it entered into the system so that your billing and payment makes sense, right? So don't be surprised if that happens. Now, just a word, because we get this question in my office very often when this happens, right? That fee schedule is out, fee schedule payments get issued, and something Congress does to help out changes the fees so that claims are not going to be paid for a while. Please do not hold your claims. Regardless of what happens, keep submitting your claims. If you think about it, so there's going to be a new fee schedule, and the Medicare program may, I have to say may because I have seen no notice, may put a hold on paying claims for a while so that they can be paid properly, right? You want to be at the front of the list, right? So that hold gets taken off. It's the claim that came in the longest ago that's going to get processed first, right? So be at the front of the line, not the back. If and when they do that, holding claims for a while, it shouldn't impact how you do business, but you might see a slowdown in when your payments come, but at least there'll be more than if they came today. Telehealth. So some policies for telehealth coverage are revised in the fee schedule rule. And it's been that per CMS and another bill, some Appropriations Act that Congress did earlier last year, that pretty much everything we know was going to be in place until at least the end of 2023. And even if the public health emergency ended, say in November of 2023, we'd have another 151 days to do everything and rework how we do things for things that weren't in place anymore. This omnibus bill has expanded all telehealth and its flexibilities through December 2024. That's a good thing for many reasons. One, okay, fine, we don't have to worry about this. And I don't know about the folks who are listening in. I love it that I can have some telehealth visits. For anybody who's working, and at this encounter with my provider, I don't need a physical exam, right? You know, they may do one each time they see me, but it may or may not really be important today, right? You know, I hate to say that about clinical stuff. So it's very helpful for me to not have to drive to the doctor's, park the car, then wait, even if it's a short wait, 10 minutes, right? I probably lost at least a half an hour, and I have that half hour on the way home, right? I can use that hour to be productive, right? So telehealth is a boon, right? It's a boon for people who have difficulty driving, getting into the doctor, et cetera. So, and we know all that, but you know, there is going to be a time when it does end. Let's hope that Congress has continues to work on what will that mean, which is why they've given themselves and you till the end of 2024. So we've almost got 2 full years for them to sit down and say, okay, what's worked? What do we need to make permanent? Yay, et cetera, right? So, but at least you won't see any changes through the end of next year. For any interventional pain folks, CMS has created a bundled payment for chronic pain management. Your quality payment program, your MIPS, right, has minimal changes. And actually there was a reduction to the MIPS payments that is also been, the reduction is not as bad as it was thanks to the omnibus bill. Right? All right. Remember I had said at the beginning that you had to be careful or pay attention to CPT says this, But what does Medicare actually say, right? And we all know that when it comes to payment guidelines, most payers follow CMS. So he give you an example or two. So for hospital evaluation and management services in the CPT code book, if you were to read the guidelines, and again, unless you're a radiologist or pathologist, I'm hoping someone in your group actually will and then communicate the information. CPT now will allow for hospital evaluation managements the reporting of multiple services when the patient is admitted during a visit. Oh, I see a typo. There are no ants in my talk. A visit at another site of service. So it's been for years that if I was seen in the office and then admitted to the hospital was a per day code, and the doctor would only be able to bill the hospital visit, combine the documentation, et cetera, right? All right, nope, no longer per CPT. And CPT says append modifier 25 to the initial service and report the hospital-based service without a modifier, right? So to E&M obviously needs to be a modifier 25. So there also then needs to be two sets of documentation. So the doctor can't dictate or type in or use voice control for the office visit and then use that as the H&P for the hospital admit, right? So that's what the AMA says. Yes, the AMA and CPT. CMS, not so much. Nope, CMS is keeping its policy that the clinician should only report one service. And in the example here, it's the hospital service per calendar date. I think if it was me, what would I do? You know, I hate to make any recommendations or suggestions that could ever have a negative impact on physician reimbursement. But, you know, I would probably just keep using CMS's rules because this is probably not something that happens all that often. And I think I'd rather be safe in what I'm admitting. But depending on your practice, you may want to find out, okay, we know this about Medicare, but which of the other payers will not look at it this way, right? Will follow CPT. And when I say Medicare for payment policy, I mean Medicare, not First Coast Service Options. That's just one contractor. So it is First Coast Service Options, but it's also all your Medicare Advantage plans. Split or shared visits, something that CMS tackled last year. Now understand, in your office practice, assuming that you are a community-based physician, you don't work for a hospital, you have incident 2 services, right? Whole other topic. You cannot have a split or shared visit. So you can't bill based on the documentation of both you, the doctor, and your non-physician practitioner because you both saw the patient today. You know, roll that up into one code, split or shared visit. That doesn't work with place of service 11. But for those of you who go to the hospital, go to a nursing facility, since CMS changed last year where a shared visit can be as in a facility setting, right? So if you do have a non-physician practitioner and you're both going to the hospital, your nurse practitioner maybe sees the patient, does most of the workup, you come in later after hours, you're finished seeing your office patients, review all the notes, the tests, et cetera, go into the patient's room, make sure they understand. That's a shared visit or a split visit, right? That is allowed there. The payment question, of course, is who do you bill under? CPT code book makes it sound as if, well, it actually doesn't say anything as to who to bill under. So implication though, or inference for most people that I've spoken to is that, well, I get to bill under the doctor. No, not so much. If you really read the guidelines in CPT, it doesn't say. So CMS says that they will pay, so who should be on the claim, for the practitioner who performed the substantive portion of the visit. So even though there's no requirement now for a history, exam, medical decision-making, right? It's not how you choose your E&M code. It's complexity of medical decision-making or how much total time did you spend today? It's which practitioner provided, well, let me rephrase it. If the physician performed the substantive portion of the visit, you can bill under the doctor. Substantive portion this year is if the doctor performed and personally documented the history or the physical exam or the medical decision-making, so the assessment and plan, you get to bill under the doctor. If you're choosing the hospital code based on, or nursing home code based on time, whoever had 51% of the total time gets to bill. Now, next year, 2024, unless the medical community is able to finally to get CMS to change the error of its ways, it will only be time. It was supposed to be that this year, but I think CMS heard loud and clear from physicians and their associations that nobody is counting out how much time the doctor is spending or the amount of time the PA or the nurse practitioner is spending in the facility setting. So they're giving you another year to figure out how to do that. Oh my God. So, but know that there's no such thing in your office practice. Telehealth. Well, you see, I also had to X out what I knew, right? When I first put this together, category 3 codes will be covered through the end of 2023. Nope. As I already showed you, telehealth, as you know it, it will exist through 12/31/24. So not until 2025 do we really have to worry. I realized I didn't say it. So the flexibilities that might end the day after the public health emergency is over, regardless of telehealth being provided, are things such as, remember, the Office of Civil Rights for HIPAA has said, look, during this public health emergency, because we know it's so important to have patients be seen without necessarily having them be exposed to viruses, et cetera. And not everybody can handle a smartphone, has able to do FaceTime, et cetera. So, and we really don't want to limit you to, to a HIPAA compliant, really secure system. So don't worry about HIPAA for this, right? You know, obviously be reasonable, but you know. So no business associate agreements needed with the application that you're using for your telehealth, et cetera. That type of thing is probably going to expire when the public health emergency expires, right? So, and I'd already mentioned the audio only services are going to be continued for telehealth for now. But also things like the telephone codes, audio only. Unless something happens in Congress, they won't be covered after January 1, 2024, right? So remember that for telehealth, we now have to report not only modifier 25, but when the service is audio only, modifier 93. So coding billing needs to be aware. And for the clinicians who are actually providing the telehealth, does your documentation allow the payer, your staff, to look at it and know how you delivered this telehealth service? It's really important, especially now that you're going to be reporting a modifier to say audio only. Does your audio video telehealth encounters actually clearly state that it was audio video, right? So something to think about. Continue to use the place of service code, reflecting what the service would have been furnished had it been in person. So patients at home, and they normally would go to your office, but you're doing telehealth, so you don't build a service where the patient is, i.e. place of service 12 for home, it's place of service 11 for your office, right? That's what that means. So some final thoughts, because this is a lot, right? Every year it seems like a lot. Although I've got to say with CMS and the fee schedule rule, as I went through looking for, okay, what are the real important things and kind of general enough for an audience like this, right? To talk about, I actually remember thinking, oh, that's not as bad as sometimes it is. Although the final rule was over 3,000 pages, one of the longer, more voluminous ones that I've had to read in several years. So in addition to noting new, revised, and deleted codes, making sure that folks don't submit the wrong codes, right? Read the guidelines. Coding and billing staff need to read the guidelines. Whoever can well communicate with the physicians and non-physician practitioners about changes, so that person needs to understand and the clinician is going to respect what they say. Everybody needs to know them. It's one of the best ways to avoid recoupments later on. So making sure that all the information is shared, educate the coding and billing staff, right? I mean, it's distressing sometimes for me as someone who was in another lifetime, a practice manager, to be working with a practice and find out that nobody has told the coding and billing staff anything. They had the knowledge that they got by on-the-job training, right? Hit and miss where they work last, and nothing's really been explained to them, right? So it's an easy fix, good education and training for folks that work for you to feel good about where they're working and to do the job well for you. Whether you have a written compliance program or just intend to do the right things right, which is what I think compliance is all about, for any of the areas that I've talked about today that impact your practice, provide education for everybody who needs to know. Think about everybody in the chain, right? From the person who schedules the appointment to the person who enters the payment or allows the payment to flow through the EFT process and is supposed to spot for you that this payer underpaid you $7 for the service per your contract, right? So really important that everything be shared. It just hit me as I'm talking. I don't have it here. I know I did a talk. Don't remember if I did it for the Medical Society, but I've done a few on the No Surprises Act. And one of the things that was a surprise to me in the No Surprises Act was the requirement for you in the office setting to give a patient what's called a good faith estimate prior to their appointment when they call to schedule and in writing if they are self-pay or uninsured. I can't tell you how many chart reviews we do now where we happen to notice, oh, it's a self-pay patient. So we look in the chart for the good faith estimate and it's not there. This is a federal law. So educate yourself on that. This is kind of outside the topic today, but I feel I'd be remiss if I didn't share. Monitor denials for trends and proactively audit your coding and billing. I mean, in this day and age with all of the audits that are existing from all the different payers and other contractors, right? It's really, really important. All right, so how'd I do? Pretty good. All right, I see one thing in the chat. Let me see if it's a question for me. Yep. All right, please expound upon the CMS bundled payment for chronic pain management. Oh, sure, ask me a question. Oh, hi, Sonia, how are you? For something that I wasn't that much prepared for. Sonia, send me an email and I'll send you the documentation. All right, I think I actually finished a little ahead of time this year. Mindy, are you there?
I am here. Great job, Jane. You're
Thank
always
you.
so informative. Always so informative. So if there's no other questions, just to let everybody know that we did record today. So I will have it on the YouTube channel on Friday and it will be in MedLink. So if you have anybody in the office that you feel needs the information, and I will be emailing out the slides also to everyone that attended, so you can have those. And of course, if you have questions and you don't have Jean's email, just reach out to me or the PBCMS at PBCMS email, and we'll make sure that we get your questions answered. And no, we do not have CEUs for this webinar. Candace.
So, Mindy, can I do a shameless plug or would that be inappropriate?
You are more than welcome to do a shameless plug.
Okay, so I'd mentioned about at the beginning, all the E&M changes, right? Pretty dramatic for anybody seeing patients in the hospital, nursing home, at home, and of course, consultations. So my firm is providing 3 webinars. They're not free, but 3 pretty darn good webinars on the topic, 3 different dates, times of day. In fact, I'm actually scheduled myself for a Saturday morning, knowing that some doctors would not be able otherwise to get educated so you can bill and collect appropriately. So anybody who thinks that they might like to have some really good education on all these E&M changes, please reach out to my office, and you have the info on the slide in front of me, or the phone number. Shameless plug, so thank you.
And Jean, if you send me those dates, I'll put them in MedLink.
Oh, awesome. Sure. Happy to do so.
And we did have a quick question.
Yep.
It says modifier 93 does get appended to the 99441 through 99443.
Yes, it does. Okay. Yes, it should be self-explanatory since those codes are telephone codes, but so it seems redundant, but yeah, yes, 93 would go on those codes.
Perfect. So then, Jean, we'll make sure that we get your webinar dates and MedLink, so if anybody needs to attend.
Thank you, Mindy, so much. Much appreciated.
Right. Always a pleasure, Jean. You are so wonderful. Thank you very much.
Okay. Have a great day, everyone, and a phenomenal 2023.
Thanks,
Bye.
everyone.